This is Heart Rhythm TV, and I'm Daniel Alyesh. Welcome back to the ICE Image of the Month. You know, the future of pacing is leadless. And, really in the current context of leadless pacing, ICE proves invaluable. And for that reason, I'm joined today by Dr. Hany Demo of Swedish Hospital Endeavor Health, who has done a lot of pioneering work in ICE, specifically for the active fix AVEIR DR device. Welcome, Hany.
Thank you. Thank you, Daniel. Thank you for the invitation.
So first off, to set the stage for our discussion, it's the why. This is an analysis of the original AVEIR DR study published 2025 in Heart Rhythm, talking about the AVEIR DR study and looking at experience and what that means for an implantation. Now, this study really had a very nice analysis showing that it is a highly successful procedure. Now, as people gain more experience, their outcomes are better, as well as their complications. And I think this is where, a table 3 in the study, which, they outlined 11.1% complication rate for the AVEIR DR study. And a lot of those are arrhythmias. But there is I want to pay particular attention to the dislodgement rate, as well as looking at pericardial effusions, because the stakes are that much higher with a leadless pacemaker, in my opinion. You have a larger sheath, you have a larger device, making sure you have an optimal location from a tissue contact, as well as from a septal location in the ventricle is critical relative to your traditional transvenous devices that are a lot smaller, quite frankly, with less collateral damage. So Dr. Demo has done a great job narrating a couple cases he did of the AVEIR DR using the Med-in-Box program to really narrate and show simultaneously ICE as well as fluoro views for implantation of the AVEIR DR. So I'll take us to our first image here, Hany, and I'll have you narrate the video, and this will also talk about this unique ICE view that you get to verify septal contact and also some of the pitfalls related to doing an ICE-guided procedure, starting with this ventricular portion of the device.
Sure. So, Daniel, as you mentioned before we started the video, I wanted to point something out. You're absolutely correct. This device, the sheath is big, just like any leadless pacemaker. The sheath is big, and right now, especially that we do more and more floorless ablation, whenever we go in the heart with big sheath, we rely really on ICE for safety. Nothing tells you better contact or better location or any safety concerns better than ICE. Fluoroscopy will just give you pretty much the borders of the heart, but the rest is a guesswork. That's not the case with ICE. You're not guessing where you are. You actually are seeing where you are. And when I started implanting the AVEIR VR first, I start using ICE because the sheath is big. The articulation point of the device is more proximal. So I want to make sure that as I'm navigating from the IVC into the right ventricle, I am not spending much time in the right atrium or making certain movement that might cause perforation or anything like that. And also, it helps you to position the lead in the septal position for the ventricle or in a thick tissue in the atrium. I think it is the information that ICE provides for the AVEIR leadless pacemaker is priceless. It is truly priceless, especially for the atrial lead as well. And it really enhances the safety of the procedure significantly. Now, in the view here that you have there,
Hany, let me actually just piggyback you on a question here a little bit. So, I just for the viewers or the listeners, you started off doing AVEIR with ICE guidance from the beginning. It sounds like.
That's correct. Absolutely. I started doing my AVEIR, my very first case with ice. I think my very first 10 cases for the ventricle, I did them with ice until I knew how it looks in fluoroscopy when I'm septal versus I'm free wall or lateral wall. And until this day, all my AVEIR atrial devices are done with ice. As you mentioned in the paper, the slide that you just had there, the biggest percentage of bad outcomes in the report that was reported was cardiac arrhythmia. The second biggest with intraprocedural dislodgement, followed by post-procedural dislodgement. These are the biggest ones that happen. And I do believe that ice significantly lower the incidence of dislodgement, and in addition to enhancing the procedural safety about like effusion, are you attaching or fixating this device in a thicker part of the atrial tissue or in the septum, it gives you a lot of invaluable information.
Well, I agree. The heart is invisible on fluoro, and the tissue contact metrics that you use for the atrium especially are surrogates, but I think let's save our discussion. Let's give the viewers what they want, and let's go to your first image where you're talking about ventricular device placement.
Sure. Yeah. So in this view, Daniel, the ice catheter is in the IVC. I have some flexion on it. The device was exposed to establish communication with the programmer, and then we advance the protective sleeve over the ice and over the device, and then we advance the device slowly from the IVC into the heart. I always want to see how it looks on ice. As a matter of fact, at this point, I don't even use fluoroscopy. Up to this point, it's mainly ice guided. And then once we're in the heart, this is our home view. I clock and counter my ice catheter to figure out where is my device exactly. And as I mentioned earlier, the articulation point for the sheath is very proximal. So when I'm doing the flexion on the sheath, I want to see my device crossing the tricuspid valve. I want to make sure that this device is not going to the atrium, is not pointing posteriorly towards the coronary sinus, is not going in any area that will be a dangerous area. So here we do the flexion, and I will clock the ice slightly, and you see crossing. Right now I'm going to clock it, and we are crossing the tricuspid
And I'm going to hit
valve.
pause there just for 1 second because I want to show to the viewers, if you're doing a fluoro guide procedure, often, trying to cross the valve can be a guessing game and a guesswork, and the appendage lives close by, etc. So really, I want to emphasize how easy it is in this inflow outflow view to see you crossing the valve, and you do a very nice job. Anyways, I'll let you keep going.
Yeah. And again, this is valuable information that the ice will give you. So now we crossed the valve, and we start getting some ectopies. And then we'll do, now that the device is in the ventricle, we're going to do the different maneuvers that we do to make sure that we're in the septal position. So now from the home view, I did a leftward tilt, and that opened the RV. You see the lateral wall. You see the device there in the lateral wall. So definitely you don't want to implant there. This is a very, that's a thin part of the ventricle. It's a dangerous area to implant. So we're going to maneuver our device by clocking the device and the sheath and maybe apply slight deflection, and we pulled back from the lateral wall. In the bottom of the video, there is the apex. You want to, of course, stay away from the apex completely. And now we're added some deflection and a slight clockwise movement, and you can see that we are mid-septum, which is a great location. It's a good location to have good eye-to-eye communication. Part of the device you can see touching the tricuspid valve, but keep in mind that the docking station for the device is the one that's at the tricuspid valve. The device itself will clear the tricuspid valve for sure. And again, here it's a thick part of the septum, as you can see on the view here. And that will be our starting point to check for our sensing and impedance and our pacing thresholds as well.
Yeah, I think this is a beautiful example of how you get to the place safely. You identify the apex really well. Getting that leftward tilt getting a view of the septum, seeing a little bit of the left ventricle on the other side of it. It's really great. And then at the same time, the path of least resistance, at least initially, was for you to go into that free wall. And
Right.
that's the stuff of nightmares right there,
Yeah.
you know? And so really you had a very beautiful adjustment with no guessing game to get onto the septum. So ICE guidance here I think is huge. And I just want to just point out all those great things you did.
Yeah, absolutely. And you minimize contrast as well, then, because you already know, like when you inject contrast in this position now in the septum, you already know what you expect. You're not gonna keep injecting contrast, or you're not guessing or any of that.
Well, thank you. So I think that you hit on an important point about the atrial component of the veer, always using it. One of the differences is with the ventricles, are you putting the system down into the ventricle, you're pushing down. In the case of the atrium, it's hanging down and you're pushing up into it. And so intraprocedural dislodgement or delayed dislodgement related to just that mechanism of how you deploy it is intuitive. So I'm going to go on to your next image here, where you obtain a beautiful view of the right atrial appendage. So I'll have you narrate, in addition to your own narration, of the med-in-box imaging. And I think this is a critical way to really bring out the appendage. So let's go to the image.
Coming on. So that's the appendage right there. So here, this is the appendage area. And basically it is the same view we receive the SVC, like when we do our transeptal view. It's just you're gonna add a leftward tilt as well and advance the eyes. And the leftward tilt is going to vary from a patient to patient. So it's not going to be extreme left or midway. It's just you're going to be dialing it in until you see the appendage. So here, this is a rightward tilt and we see the SVC, and then I start going leftward tilt a little bit, and that's when we start seeing the appendage there. And if you keep going more leftward, you start seeing the aorta because you're going to be going more anterior. Okay, so that's the appendage here. All right. SVC and the.
So as it's as mentioned in the video, just adding a slight leftward tilt from the view where you do the transeptal is important. The one thing that also we have to keep in mind, we have to add a more posterior tilt, because you want to be more on the floor of the right atrium looking upward. So posterior tilt and a leftward tilt, and you can start seeing the thick part of the appendage, and you can actually guide your implant based on your eyes. That will minimize time, minimize risk of any perforation, and also minimize the chances of your reposition. As we learn, every time we do an AVEIR case, we learn something new. We're still learning something new. But the one thing that we know for sure is when you keep moving the AVEIR, you end up with a lot of tissue edema, and the atrial tissue signal is very is not like the ventricular tissue, as you mentioned, Daniel. So the more you move, the less satisfactory numbers you're going to get an implant. And as you mentioned, is going to be a guessing game. So if you choose based on ice, a thick area to begin with, I think it just saves you the whole hassle.
Yeah, no, I think that you're bringing yourself off the septum with your posterior tilt and really splaying out the right atrium more as you bring yourself off. And at the same time, I think you're absolutely right, right? The appendage, the right atrial appendage, I mean, one thing that you would appreciate from anatomical dissections is the right atrial appendage is a good portion of the right atrium outside the venous right atrium. And then you can appreciate that if this on the ice image, the amount of septations that you see, it also can be quite thin in certain areas. And that's why you can appreciate ice. And then you can understand whether you're going to be thick, you're going to be safer. And you're maybe going to get a better signal that way. Hany, question for you. Are you always putting the device into the appendage, or are you putting it at the base of the appendage too? What is your thinking there?
What's recommended by Abbott actually, that you should not put it inside the appendage, because that's where they had, I think, the perforation and also some dislodgement. But I honestly, Daniel, I do I don't do at the apex. But I wouldn't be shy to do it inside the appendage if I see a thick landing area or a thick fixation area. And basically just for better eye-to-eye communication as well. Base of the appendage will be ideal, but if I don't have a good tissue characteristics at the base, I'm not shy to go inside the appendage and take a good fixation at the pectinate muscle that we see here.
Okay, so let's then we'll move on to your deployment. And then you have the side-by-side med-in-box, fluoro, and ice views. And I'll let the viewers be the judge of where they think they're getting more information, but resume.
Yeah, so this is here, we moved it to a thicker tissue area here. That's our point of contact, and the P waves here are now at 2.2. And the pacing threshold, what was the pacing threshold before we, 1.5 just with contact. So I think we like it. We'll just go ahead and try deploying here. And
So one thing I'm realizing is your fluoro view is not moving on this med-in-box image because you are largely using ice at this moment, right?
Correct. Yep.
So you're not getting a lot of information from fluoro because it's not on in this picture. But talk to us about why you chose this spot and what you're seeing in this image.
Yeah. So this patient, as you can tell from the fluoroscopy image, had an open heart surgery before. The right atrial appendage was scarred. If you look where we basically at the in the bottom right there, that's scar exactly. That's a very echogenic tissue which scarred out, and we mapped in this area, and we could not get any good P wave measurements. And if you look above it, if you look at the area where you see the pectination itself are thick, but in between, you can appreciate how thin this is, and you see it more when it's moving live. So we finally were able to get a little bit deeper in whatever left in the appendage, and we find an area that has a thicker pectinate, and we just basically fixated the device in there. So, and ice was very instrumental to really direct us to not only avoid the scar, but also avoid the thin area and implant in an area that's much thicker, and we can kind of fixate the device without, risking perforation or dislodgement.
Excellent. Okay, so now we'll bring our next slide here, talking a bit about the short tether test, which is designed to say, how well am I fixated to the tissue? And I think your images are quite illuminating for seeing what that actually looks like and what good tissue fixation looks like. So I'll play the slide in your med-in-box narration.
okay, so we're gonna go into short tether first, yeah? All right, and the device is stable. We see it's on ice as well. Okay. All right, so we're doing a tension test here, and we're damping down the movements, and we see it on ice also stretched out all the way. We're stable there. Perfect, okay. Okay, and we're gonna release right now. So we'll just stretch it out a little bit, and then I'm gonna release, yeah.
All right, Hany, so talk to us a little bit about when you're doing that tether testing, the benefits of ice, which I think are many, as an example.
Yeah, so this is the same patient that we were just talking about having open heart surgery, and we finally have, you can see here, Daniel, it's the thick area that we were able to direct our device in. And we did like a good tension test. You can see the device straighten out, the tether straighten out, and even pulling a little bit on the appendage. The appendage is caving in a little bit. And this is very, very valuable information. On fluoroscopy, you can see the damping of the movement, but you don't appreciate how much you're actually pulling on the tissue and how much of a good fixation you are until you see it on ice, as you can see there. And you can see that you're fixated in the, there's no movement of the device helix. You don't see the helix coming out. The device is very stable.
I agree. And I think sometimes, especially maybe you've done a couple of deployments of the AVEIR, you have some tissue edema, you say, hey, my lead parameters are good, but can I make them better? Right? But in this situation here, especially if you have ice, you're going to be able to look and say, hey, my tissue contact is really good here. I do see some of the edema. I do believe these metrics are going to get better. Whereas with the fluoro image, you say, hey, I think I see some dampening. I can impute where the heart is. So I think there's a big difference there. So Hany, a beautiful example there.
Yeah, thank you, Daniel. And you're absolutely right. And you hear of cases that at the time of implant, the damping was good and the tether was good, and then the next day the AVEIR, the atrial lead was in the femoral vein. It dropped all the way down. IVC, I apologize, not in the femoral vein. Even though it met all their own past criteria, if you would, but it still did dislodge later on.
Yeah, no, I think that, as I said, the future is leadless. I think as this technology matures, I think we're gonna, the journey is gonna be towards most of us going this direction. However, as we work through the iterations of this technology, I think ICE gives us information that is so critical. Thank you very much, Hany, for this wonderful case or for these wonderful cases and these wonderful images. I want to actually, for a second here, talk directly to the viewers and say, hey, ICE Image of the Month, many have joined this program, are reaching out directly to me. And I would encourage the viewers, if you have a great image or a great technique or something you want to share, please email me, daniel.alyesh@gmail.com. I think the bar is very intimidating as far as with Hany's images, but I suspect that there are many, many great eye practices out here. So, Hany, any final thoughts for the viewers?
Thank you so much, Daniel, for inviting me to present about the AVEIR. The one final thought is ICE is also going to be very, very valuable for extraction of these atrial leads as well. I did an extraction recently of an atrial device, not because of a battery issue, but because of other reasons, patient specific, and we ended up taking out the device. The using ICE honestly made it very, very simple, very straightforward, very low risk procedure.
Well, thank you very much, Hany. I think excellent points, and I think you've made the point. I want to make the point to the viewers that these devices need to communicate, eye-to-eye communication. And I think understanding the ICE views and where the optimal locations are will also help with that. So, Hany, thank you very much for joining me, and thank you all for tuning in to Heart Rhythm TV.
Thank you, Daniel.